TechNation editor John Wallace here. Today we will learn more about the Claroty xDome and operational efficiency. Connectivity in modern healthcare networks has dramatically reshaped patient care delivery. Clinical workflows depend on connectivity, requiring proper governance of Internet of Medical Thing devices to ensure operational efficiency. This Tools of the Trade demo will dive into the operational efficiency module of Claroty xDome, which helps clinical teams leverage device utilization, location, and operational status. It helps to ensure optimal use of device resources and to help more efficient operation planning and smarter capital expenditures. Key areas that will be covered in this demo include inventory reconciliation, utilization and lifecycle, resource optimization, and physical location tracking. Thank you to today's sponsor, Claroty. As the world's most trusted healthcare cybersecurity company, Claroty empowers HDOs to comprehensively monitor and manage risk across their healthcare extended Internet of Things environment. Whether it be through a medical device or a building management system, attack surfaces grow as connected assets expand, creating security blind spots that pose risks to availability, integrity, and safety. Claroty tackles these risks to ensure cyber and operational resilience are within your reach. Visit claroty.com, find out more. All right, now it's trivia time. We're going to give away a multi-tool. The question is, NASA's Artemis II is scheduled to launch later today, marking the first crewed mission to the moon in over 50 years. The 10-day flight will carry 4 astronauts. What year did the United States put a man on the moon? You can answer using the dashboard. And while we're having those answers come in, I do want to remind everyone that the attendees are invited to download the documents in the handout section of the dashboard. Those will be very useful information to have. All right, wait a little bit longer while those answers are coming in and we'll move along. I want to remind everyone that today's presentation is eligible for 1 CE credit from the ACI. 1 hour after the end of today's broadcast, you will receive an emailed survey. Completing the survey will grant access to a certificate that you can download and print from your desktop. We will wrap up today's broadcast with a Q&A. Please note that the webinar dashboard includes a questions feature. You can submit your questions for our presenter at any time during the demo, and we will have the Q&A towards the end of the presentation. Today's presenter is Claroty Field CTO, CISO, and distinguished cybersecurity professional Skip Sorrels. His 25+ year career began in nursing across Texas ICUs, trauma units, and transplant teams before his passion for technology led him to Dell. He later became the director of cybersecurity at Ascension Healthcare. Skip established a successful medical device cybersecurity program over 6 years while at Ascension. This achievement expanded his role to developing OT cybersecurity programs and exploring XIoT security. Skip, you may begin whenever you are ready.
Thank you, John. Good afternoon, everyone. Welcome for joining. Thank you for joining and welcome. We're starting out here. I'm going to give you a little bit of primer. Everything in the platform that we're capable of doing is based on the passive interpretation of packets across the network, typically coming off of a span on a switch. Why is that important? It gives us the ability to fingerprint any network connected devices and determine what they are, up to and including, funny enough, automobiles that are tethered to cell phones that may be attached to corporate networks. What you're seeing here is the opening screen of our dashboard that gives you a breakdown of the device counts and categories, total devices here at the top, corporate network versus guest network, and then a breakdown by device type: medical, operational technologies, IoT, and IT. You'll notice also a breakdown by manufacturer, protocols, high-risk devices, device family distributions, and alert types. Why is this important when it comes to operational efficiencies? Clinical teams are able to leverage the platform and gain insights regarding utilization, location, and operational status of devices, among many other things. So we'll jump right in. If we go to our operational efficiency dashboard, the first thing that we see here is our recommendations screen. Basically, we provide alerts, if you will, within the dashboard that provide recommendations around efficiency considerations to be taken, addressed, or otherwise disregarded. You'll notice the relevant devices by recommendation type. You have offline rented devices, underutilized rental devices, offline devices, end of life, overdue preventative maintenance, and so forth. We've got efficiency recommendations here by device type, total number of recommendations, relevant devices, unresolved recommendations. And if we move to the inventory section, we start to visualize an area that is extremely important, and that is our ability to integrate with CMMSs and CMDBs. Specifically for clinical engineering or biomed personnel, this is extremely important because this reconciliation process allows us to triangulate what is on the network versus what is seen within the CMMS and validate that the CMMS has the most accurate information as well as no gaps. Other information that's gleaned that comes from that integration is information related to the end of life or end of support of that device, if it's captured within the CMMS. We also can get information regarding devices that have gone missing and so forth. And we'll jump into that a little bit more here in a second. The section here regarding location, we're basically able to triangulate devices that are Wi-Fi attached on the network. We can also triangulate devices to hardwire. It's a little bit more difficult, but we are able to determine the port that they're connected to, ultimately the router, and then the switch. So we can see the chain down from the switch to the device. If you look at the number of devices located here, wireless devices, wired devices, campuses, buildings, and floors. Located devices by device type, wireless devices by campus. And if we start to look at the utilization here, we start to see CT scanners, infusion pumps, bone densitometers, nuclear med, and so forth. Average daily devices in use by device type, again broken down. Infusion pumps, average daily devices in use, and peak concurrent devices in use. And it trickles down from there. Unused devices by device type. Again, another distillation of device by quantity and unused devices. I'm going to take us over to this section now. We'll do a drill down on the CMMS reconciliation because that's quite important. We want to get our data set correct and synchronized between the two platforms to create enablement for the clinical engineering teams or clinical application teams. What you see on the left-hand side are those assets identified as xDome devices, meaning we pick them up through packet inspection and have identified those, and then correlated that information to what we're receiving through the API of the CMMS integration. And you can see how the gaps begin to distill down following the vertical Sankey diagram, basically. So you've got manual matching, suggested matches, CMMS suggested matches, and manual matching. What we're looking for here is a synchronization and then answers to why there are gaps in these numbers, which may reflect data integrity or data governance issues, or possibly devices that have been marked as retired in the CMMS, but for whatever reason weren't retired from the environment and therefore show up on the network as still active. We can drill a little bit further and look at the matching distribution. We have a indication of the unmatched devices, devices with serial numbers, devices with MAC, and suggested matches. We do a breakdown by manufacturer and a percentage of matched devices here on the right. We get an indication of the total device count, the matched devices, unmatched, and matched and model. All right, we take it a step further. We'll take a look at the matched devices. Same view. The point being here, these devices are matched by serial number and model, or matched by serial number and manufacturer, matched by the MAC address, and we have 0 that are manually matched. Same view here. The difference being we now have site names for the location of these assets, and additional information that we glean from packet inspection and the CMMS integration. Lastly, we take a look at the unmatched devices, and these are devices that need to be looked at from a gap analysis perspective. We have the ability to look at the connection types, the location, and start to drill into the data set to perform a matching process if it's possible. So we've got here at the top the devices that are unmatched in xDome, and then devices here at the bottom that are unmatched CMMS assets. Now we're going to jump back to utilization. Why is utilization important in healthcare? From my own experience in healthcare over the many years, I as a nurse can attest to the fact that we're hoarders of equipment. And often we will hide things because we're afraid we won't have it when we need it. And it also becomes a problem because, as an example, infusion pumps tend to represent one of the largest assets that's over purchased or over leased in healthcare based on a lack of visibility of what's actually in inventory and what's being used and how often. And we're able to look at the utilization of, say, infusion pumps. And in this example, we've got pretty high utilization on these assets, which I would say is actually very uncommon in healthcare for an infusion pump. What I have seen across close to 200 to 300 customers that we have that are in healthcare, the average is somewhere between 15 and 20%, representing a huge opportunity for cost savings in terms of returning leases and establishing better fleet management through clinical engineering and depoting options. If we look at devices that fit in the optimal range, we're categorizing them by the device type. We're giving a representation of their utilization, and our indication that it's in optimal range is based on our ability to benchmark across the hundreds of customers that we have in healthcare and associate it to bed count and a couple of other factors and come away with a baseline optimal range. If we then take a look at overutilized devices, infusion pumps come up as overutilized, and there are several other examples here, maybe indicating an opportunity to have a lifecycle management conversation. Specifically, I would say that I would look at the devices that are overutilized, and what I would first want to know is, are they end of life and end of support, and they're being held onto for whatever reason? Is there an opportunity to replace them and upgrade them? Or if they're current in their life cycle, is it an opportunity to add a few to the fleet? All considerations back to budget, the facility, and how they manage their money and capital expenditure. We also have the ability to look by site-specific indicators. We represented that previously. So if we take a look at the site in the demo here for Albany, we see that there's a C-arm, a bone densitometer, and a hemodialysis device, all running at 95% plus utilization. We have the ability to do subcategorization of our assets: clinical IoT, lab, imaging, patient devices, and surgery. Switching gears, we'll take a look at location analysis. This is somewhat of an eye chart, but across the top is an indication of the device type, and along the left, vertically, is the location, building 3, floor 3. And it appears we have one medical device. In addition to that, we can slide across and we see patient devices listed here. Infusion pumps, we have infusion pump modules, vital signs monitors, defibrillators, anything and everything that's network attached that we can pick a packet up and inspect it and fingerprint it. Again, the same capabilities exist here at the top with regard to sub-delineation by site, network. We can say, do we have any devices that are on the guest network? That would not be very good. I have seen it many times across many customers, including in my own experience, where medical devices have ended up on guest networks, typically because it's easier just to go and connect to the guest network than it is to get a certificate or the appropriate SID to make the right connection. We can also look at the categorization of assets, again, breaking it out by the 4 categories that we listed on the first screen: IoT, IT, medical, and OT. We have subcategorization of those categories, breaking down further the IT, the medical, patient devices, building management. So when we get into operational technologies, now we're talking about building management. We can look at it by virtue of manufacturer, device type, model, and then we can do an additional location filter. Why is location important? For the same reason that we have underutilization with devices, and I'll call upon infusion pumps again, they move around and often they go missing. And the cool thing that we have with our integrations with wireless infrastructure is the ability to pull from that wireless infrastructure building maps. The building maps are also associated to the wireless access points which beacon. And we are able to pull up a map and look at the devices in Albany, building 6, floor 1, and actually see where they are on the map. So for a technician that's got a break fix ticket or preventative maintenance and they're struggling to find the device, they actually can leverage the platform to locate it. Here in this case, we have one device, and we could actually zoom in and zoom out. And depending on the radius of the transmission of the wireless access point, you typically can be within 100 to 150 feet of that asset or less, depending on the, the density of the wireless access points on that floor. The interesting thing here is while we have numbers that represents the devices, we down here have actual device stratification by a manufacturer. And so there are several different ways that a technician could search for a device. They could use a search screen here. If, say, they knew the dry mouth. Let's say that we had a MAC address or some sort of unique identifier that was associated from the CMMS to the ticket that was issued. And we wanted to come in here and we could go about searching for it in a multitude of ways. But if we were in this screen, we could just actually drop in. If we thought it was supposed to be in building 1, we could then just drop it in the search window, search for it, and verify if it's there. If it's not there, we actually can go to the top and perform a search across the entire platform. and identify its location and then drill into it for the map. Additional considerations, in some organizations, most, they have what's called a missing device, cannot locate, or some other form or fashion. And the challenge with that, as we all know, based on HIPAA regulations, there are certain devices that contain PHI, and if they go missing, it can be problematic and often, or I shouldn't say often, but could result in having to file a report with the OCR regarding exposure because we don't know where the PHI within the device is gone. So there is a way to establish alerts within our system indicating when the device is online, when it was last seen, and if it comes back online. Pardon me. So let's say we had a cannot find program. We could set alerts for devices that hadn't been found based on a certain period of day, and we can make a simple alert that says when they come back online, alert me to the fact that they've rejoined the network, which then gives us the ability to look at the beacons on the map potentially and find that device. If we look at efficiency recommendations, our recommendations are based on the type, obviously, underutilized rented devices, several other options here, end of life, located lost, offline, several different ways to slice and dice this data to look at and understand why the recommendation was made, and then make a determination if action should be taken, and the ability to mark it as resolved when the devices have been addressed. In this case of underutilized rented devices, as I mentioned earlier, a big opportunity to consider cost reduction, which in turn could be correlated directly to a return on investment of the platform itself. If we were to look at end of life and end of support devices, in this example, end of life devices often represent higher risk because if they're also end of support from the manufacturer's perspective, won't receive any additional patches from the manufacturer. And from my experience, I coined the term cyber dead, meaning the device is end of life and end of support, cannot receive patches, and then we have to consider risk mitigations such as microsegmentation or retiring that asset. Often these assets, even though they're end of life or end of support, are not at the end of their useful life. And that's a function of parts availability in the marketplace and the technician's ability to seek and get those parts in a break-fix environment and continue the useful life of that asset. Operating hours configuration. Why is this important? When we're considering the utilization of devices, the default within the system is that it's 24 hours. But we all know that different locations are not 24 hours. And therefore, changing the operating configuration of a particular location, for example, will shrink the time frame and give you a better understanding of the actual utilization versus it being distilled down to a number that is not really relevant in a 24-hour period. So we can adjust these operating hours based on our understanding of the environment, the location, the department, or the clinic, and we can make changes to these attributes and thereby cleaning up and further improving our operating hours, and ultimate utilization numbers that we saw on the previous screen. I'll just go back to that real quick. So in a situation where you have underutilized devices, we might want to take a look at that and understand the device and its location and go and verify whether or not we have the proper operating hours to see if that affects our activity rate or our utilization. The compression of time from 24 hours down to say an 8-hour or 12-hour window certainly will drive up the percent utilization and give a more accurate understanding. Let's now move to inventory benchmarks. Inventory benchmarks we've established based on having the largest med device database with an active understanding of utilization. And basically what's represented here is the device type. And you'll notice in this scenario, we have 58 devices, 55 devices above benchmark, because what we see across the industry, on average per 100 beds, there's 11.2 of these devices. And you can look at this from the perspective of, are we over provisioned or under provisioned? So this plays into the ability of procurement. So often I have conversations around the overleased infusion pumps or considerations for additional purchases. And when I inform procurement and clinical engineering or clinical applications or whomever is involved in that procurement process, and they're able to look at the devices per bed and understand the utilization, they often can make better buying decisions. And rather than approving a purchase, unless it's absolutely necessary because all of the current assets or a large portion of them are being retired, they can avoid paying for additional devices that then become even more underutilized. So this becomes a powerful tool in understanding the lifecycle management as well as the procurement opportunities that may exist in an organization, and the question of whether or not they should or should not buy. I'm going to jump back to the overview and do a couple of additional drill downs. If we look at, say, let's see, patient monitors, we'll notice that we have 15 unresolved recommendations just in this category alone. And we can drill into the device type from that first screen rather than jumping around and get to an inventory of devices that fall into different recommendation types, but they're all grouped by the device type. In this case, we have, again, end of life, located lost, going back to my cannot locate or cannot find representation, devices that are offline devices above inventory, possibly indicating an opportunity to reduce the fleet of that particular device in that location. And then the recommendations that go with it. 757 devices that are labeled as rented in the CMMS and are underutilized. Another interesting use case that we've seen is in using this utilization capability or operational efficiency. There was a particular organization that kept coming up short on, I believe it was vital signs monitor, actually infusion pumps, again, another one. And they started looking at patterns of connected devices that went offline and then looked at that offline date and looked at the location, and what they discovered over about a month and a half of doing the research is that these devices were leaving the units and going to the loading dock and being loaded on trucks and stolen, and then I guess resold on eBay or some form of black market, if you will. And they were able to further their investigation and proceed with identifying the perpetrators. I'm going to go back and let's talk about let's jump into this unused device type. Glucose meters. Glucose meters disappear all the time. Most of the conversations I have around this and trying to solve for it is the RTLS tags are too expensive to put on a glucose meter. Some organizations choose to do it and some don't, but these things seem to go missing. And so the question becomes, are they showing up as not being utilized because they've walked off, disappeared, got thrown in the trash inadvertently or whatever? And so you have a way to look at the number of devices that are online on average and the peak concurrent and so forth. If we look at the overall rate, you have an 83% activity rate and 39 of these are underutilized. If we take a look at those devices, we can get down to, again, the location, the IP, the MAC, when it was last seen on the network. You'll notice here corporate, differentiation between device type and manufacturer, what the model is. And as I mentioned before, we start to see these last seen indicators. We're able to pick up the last time it was seen and a status. And in this case, this device was seen as online at this time. This device is indicative of being offline. The last time it was seen was March 7th, and it's been offline since then. You'll also notice that we provide a risk score for these devices. Typically in a glucose meter scenario, indicative of a firmware or a application that manages these glucose meters. We have the ability to provide labeling for assets. Labeling might be a support organization or department that can be added here. You can add assignees. The assignees might be a clinical engineering or biomed tech that is running the cannot locate, cannot find device program. And by adding an assignee, that goes back to our ability to create alerts that can be sent to the assignee when the device comes back online, making it easier for them to retrieve it, bring it back into the fold, and put it back out for production. I want to take a look at the recommendations for based on efficiency. In this particular inventory, or I should say recommendation, we're looking at 104 GE dash patient monitors that are end of life. And basically we further our recommendation by considering using compensating controls and check the manufacturer for an extended support availability to possibly extend that usage instead of purchasing a new device. Or if we find that they are also high risk, we would definitely want to consider working with a cybersecurity team for a segmentation play if it's not already in place to mitigate the risk. Again, going back to utilization, I know I'm kind of jumping around. I'm just trying to tie all the data points together. This is yet another example, underutilized 100%. And if we take a look at it, we'll notice that it's an exposed medical device, meaning it apparently has a connection to the internet, and it's considered to have critical vulnerabilities. So not only are we able to look at efficiencies within this platform, we have so many other capabilities around vulnerability identification, exposure to the internet or exposure to threat, and the ability to look at these devices from a risk view as well as a utilization or efficiency view. Again, to recap, we're able to integrate with CMMSs and CMDBs, perform reconciliation of the two data sets to ensure accuracy and no gaps in that data. We're able to pull in the information from the deep packet inspection, which allows us to understand the utilization of the asset. We're able to look at inventory by device types. We're able to drill down to the location of the device by device type at this highest level. We can look at an overall utilization here at the bottom. And ultimately, this is a hidden feather in the cap in terms of my own practice in the past and several of my colleagues across the industry in healthcare, where cybersecurity platforms and tools are often looked at as an insurance policy. And when we're able to use information, the intelligence of our platform, and it becomes a business intelligence tool, and we can incorporate as many departments into the use of this tool, we now have the ability to return a true return on investment or ROI, either through fleet management and cost reduction or cost avoidance from over purchasing. This becomes a very powerful conversation in the organization when budgets are as tight as they are now. We have to look at how we become more efficient, and we have to be very diligent in how we manage the fiscal, meaning financial aspects of our responsibilities as well as the organization as a whole. John, I think I'll turn it back over to you for questions.
Thank you so much, Skip. That was very good. We did have some questions come in, and I want to invite everyone that they can also submit questions in the questions feature on the dashboard. The first question we have, and you may have touched on this briefly, but what asset types are most often discovered by Claroty xDome that were previously missing from the CMMS or CMDB system of record?
It's typically the ones that are the most movable within the environment. So your Wi-Fi attached devices, where that be a nurse bedside rolling vital signs monitor machine, an infusion pump, glucose meters, and so forth. There's also a category of devices where devices get brought into an organization and they get placed on the network, but for whatever reason, the workflow breaks down and they never get added to the CMMS. And so our ability to identify those devices that are not in the CMMS gives us the opportunity to improve the data within the CMMS, bring visibility to the asset, and understand the overall inventory.
Understand. Another question that came in is, how does asset lifecycle management offer ROI opportunities?
So I covered that a little bit, but I'll go over it again. When we look at the lifecycle management of devices in this operational efficiency, we're calling out end of life and end of support devices. We're able to understand the quantity of those devices, and then we're able to correlate the risk to those devices. So let's take a category of devices that are, if compromised, will cause patient harm. Because in healthcare, cybersecurity ultimately is about patient safety. If we can take a look at those assets that we know would cause patient harm, and we have that ability in the platform to define it, We can then look at those devices that are end of life and end of support, meaning they can't receive patches and they may not have a compensating control or technical control in place to reduce their risk. And we can make some decisions around, do we retire those assets? Are they in fact underutilized and no longer required? I actually had a situation where I was involved with the procurement team, and a question was posed regarding a risk assessment. We did pre-procurement risk assessments regarding a refurbed CT scanner, and I pointed them to our clinical engineering team, and ultimately they determined we had a CT scanner in one state that was not being utilized and was up for retirement, even though it wasn't end of life or end of support. And in that scenario, they literally unbolted it, moved it out of the hospital, and trucked it to another state, avoiding a purchase and saving about $1 million. So there's all sorts of use cases around the lifecycle management aspects of each device type, their purpose, how they're used, looking at the benchmarks to understand, are we under provisioned, are we over provisioned, and ultimately looking at the utilization as a cofactor to that.
Thank you. That was a very good answer. And I'm curious what impact, if any, is AI having in this field right now?
A lot of conversations and a lot of uncertainty, to be honest. That's probably the #1 question that I've been asked month over month for probably 6 months at least. AI can be viewed in one of two ways, in my opinion. We already are well aware that the adversaries and the hackers are leveraging AI at lightning speed to accelerate their attacks on cyber physical systems, specifically critical infrastructure with which healthcare sits within. And so from a defensive standpoint, we've got to take the tactics that the hackers use and apply those in our defense mechanisms within our cybersecurity and our IT infrastructure. There's a whole lot of different ways that AI is being leveraged within healthcare. My view is that we have got to accelerate our adoption of AI with regard to understanding the cybersecurity elements. If you take a SOC analyst who's looking at thousands of tickets a day, they have on average 10 to 15 seconds to interpret alert and decide whether or not it needs to be looked at further. If we leverage AI in those scenarios, we free those people up to do more critical thinking because we can allow the AI to function after we tell it how we want it to operate. If we look at how AI is applied within the actual practice of healthcare for patients, we all know and are reading about how AI is being leveraged for better diagnosis. The ability to look at images and understand aberrant or abnormal views and call those out. Obviously, there should always be a human in the loop in any form of AI. AI should not be a replacement, it should be adjunct. So when I talk about leveraging AI, it should eliminate the mundane work of individuals so that they're freed up to perform more critical thinking on the things that matter more and most.
Very thoughtful answer there. I can tell that you have been asked that a lot because you had a good answer ready. This kind of goes completely the other way. What level of manual effort is typically required to maintain an accurate device inventory over time?
In my experience, in the absence of having the visibility provided through our platform and the integrations into existing databases, entropy always sets in. And I would say that my experience says that inventories are very underestimated, meaning they are not up to date, up to the current caliber. And in my own personal experience, that number was quite large in the large environment that I came from. Having the ability to see everything that is on the network and make analytical decisions around why do we have a gap? What's the cause of it? Let's get to the root cause. Let's eliminate it. We're able to use the system for some workflow automation through ticketing and bring the reconciliation up to as close to 100% as we can, knowing that it will never be perfect. But I'd rather be sitting at 89 to 95%. I'd take 85% based on my own experience versus say 50%, because that 50% represents the things that we don't know anything about, and we can't protect the things that we don't know about. We also can't manage life cycle. We can't make buying decisions or procurement denial decisions. We don't need to buy that. We have plenty. So everything in healthcare, well, quite frankly, in any environment, the foundation of it is asset inventory, asset management, which allows you to perform all of the other business functions with factual-based interpretation and decision-making.
And then another question is, what is the biggest misconception or most often overlooked item that healthcare organizations have about device utilization in today's environment?
Most overlooked. I think fundamentally that organizations, because they lack an accurate inventory, are already crippled to understand whether they've over purchased or under purchased. You then couple that with the risk that's associated with things that are unknown to the organization. And I think the wow moment occurs when, at least for me, first time I ever looked at this platform as a practitioner, I went, oh wow, I had no idea we had all of that stuff. And when you start going through it and you start realizing the device types, not just the medical devices, but you start looking at things like operational technologies. Operational technologies are your elevators, your HVAC systems, your water filtration, your building management controls. And if you're paying attention to the news lately, you will notice that the hackers have been going after industrial organizations, going after those operational technologies, which, by the way, are the same operational technologies we find in hospitals. So I would just say in general, to answer that question, it's an unknown lack of awareness to what truly exists in an environment, because asset management's not fun and it's not easy in the absence of having tools to help deliver that data into the CMDBs and CMMSs.
All right, thank you. Good, thank you so much for sharing your knowledge with the TechNation community today. I do want to let everyone know that the winner of today's multi-tool for correctly answering the trivia question is Fred Donnelly in North Carolina. Congratulations, Fred. The correct answer is 1969. NASA's Apollo 11 mission achieved the first U.S. manned moon landing on July 20th, 1969. Now, a quick reminder that you can obtain your CE certificate by completing the post-webinar survey. The survey will be emailed to you in about 1 hour. You must complete the survey to receive your 1 CE credit from the ACI. And you will be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach out to us through email at webinar@mdpublishing.com. Again, that email address is webinar@mdpublishing.com. Quickly, before we sign off today, I want to mention several upcoming events for HTM professionals. The MD Expo Baltimore kicks off on Tuesday, April 7th. Also coming up is the HTM Mixer in Arizona, May 7th and 8th, as well as the HTM Mixer Northwest out in Bellevue, Washington, July 31st to August 1st. And then the Fall MD Expo will be later this year. Find all the details at mdexposhow.com. Thank you, Skip, again. Thank you, attendees, for your attention. I hope everyone has a great day, and we'll see you at the next webinar.
Thank you, everyone.